Good evening, everyone. Good evening, Shanawaz bhai. Good evening, Kakul. Really nice to see both of you after such a long time. And related to this session, like what I have done, I have chosen 5 short subjects because I thought that like if I'll be taking one subject at a time, it will be pretty boring and monotonous. So what I have done, I have taken 5 short subjects: skin, anesthesia, radiology, psychiatry, and obviously ortho, my favorite. Right. So these are the 5 short subjects, and for the ease of interest, for developing the interest in the class, what I have done, I have removed the options, right? And secondly, I have mixed up the questions, like one question will be from skin, then another will come from psychiatry, like that. So random arrangement without option. So with the hope that this will make the presentation much more interesting, right? So we can take the session, and I have included all the questions from these 5 short subjects which were asked in the yesterday's FMGE exam. Right. So the very first question was like 42-year-old male who works as a tailor now presenting with numbness and tingling in the thumb, index finger, middle finger, and radial half of the ring finger of the right hand since the past 6 months. Now, symptoms are worse at night and often awake the patient from sleep. Then the patient shake her hand to obtain relief, and there is some weakness of thumb abduction as well. Now this is a very classical manifestation of a problem. I think most of you can understand that. So if we go with the keywords in the question, there is paresthesia in the form of numbness and tingling, right? So there are altered sensations like numbness and tingling. Now what is the location? Thumb, index finger, middle finger, and more importantly radial half, or what you call the lateral half of the ring finger, right? So these are the fingers which are affected. Then symptoms are more at night, and then the patient has to shake her hand to get relief, and there is some weakness of thumb abduction. So I think the moment you get this particular paresthetic area, the diagnosis is quite obvious. So I think most of you can make a clear-cut diagnosis that there is carpal tunnel syndrome. Right? So this condition is carpal tunnel syndrome, and this is compression neuropathy of median nerve. Clear? So there is compression of median nerve as it passes through the carpal tunnel, and see, this is the classical distribution of the median nerve. So this is the classical distribution of median nerve. On the volar aspect, 3.5. So how we count? 1, 2, 3 and half here. So this is classical 3.5, which is the territory of volar aspect of hand, or you can say palmar aspect of hand. So this is how you should solve this kind of question, and this is a classical case history of carpal tunnel syndrome, and the patient is having paresthesia involving the lateral 3.5 fingers, and classical of carpal tunnel syndrome. Then there was a question which was about a young male who is having severe nodulocystic acne. Okay, so the patient is having severe nodulocystic acne, and he is being planned for treatment with oral isotretinoin as he is not responding to oral antibiotics and topical retinoids. Now, before starting this particular drug, oral isotretinoin, you have to do some baseline investigations. So, what are those baseline investigations? So, if we write the keywords here, what has been given to us? The patient is a known case of severe nodulocystic acne. Clear? So, the patient is a case of severe nodulocystic acne, not responding to what? Oral antibiotics and topical retinoids. So, there is no relief after taking this medication. Now, planned for oral isotretinoin. Okay. Now, what baseline investigation we have to do? Now, here in such questions, what you need to know, like what can be the probable complications or adverse effect of this drug. So, we should have to keep a watch on those parameters, right. So, this is the basic core of this question, that you should know what are the adverse effect, because if you know the adverse effect, then you can monitor them. So, here there are two important adverse effects for oral isotretinoin, especially considering male, right, because in female it can be teratogenic as well. Now, here one thing, that it is hepatotoxic. So, oral isotretinoin is hepatotoxic. So, what you need to do? You need to check the functioning of liver, whether it is working normally or not. So, for that you will go for liver function test, right. So, since it is hepatotoxic, so we need to check whether the liver is okay or not. And second, it raises, so we can write hypertriglyceridemia, and it also causes hypercholesterolemia. So, it is increasing the triglyceride levels and it is also increasing the cholesterol level. So, what do you need to do? You need to go for lipid profile, right. So, based on the adverse effect of this particular drug, we can plan like what investigation, what baseline investigation we have to do. And so, go for liver function test, go for lipid profile, not only before starting the treatment, also during the course of the treatment, and the moment you find that there is something wrong, you can stop the drug, right. So, that is very important for isotretinoin. Now, this is for male. In cases of female, always keep the possibility of teratogenicity, right, and therefore, do not give oral isotretinoin to a pregnant lady. So, contraindicated in pregnant lady, because it can cause malformations in the developing fetus, right. So, this is oral tretinoin, which is indicated in severe nodulocystic acne, right. So, this is in short what you should know about oral isotretinoin. Then there was a question which was image based question from anesthesia, and here some instruments or equipments were given, and you have to identify like which one is used for endotracheal intubation. Now, out of these four, which one is used for endotracheal intubation? Right. So, we have to intubate the patient. Now, as the name suggests, endo means inside, tracheal is of course trachea. So, we have to pass the tube in the trachea to maintain the airway. So, endotracheal intubation, and I think most of you must have seen a endotracheal tube, and this one is the endotracheal tube here. Okay. So, this is the endotracheal tube. Okay. So, very easy to identify provided you have seen that. Then this is a laryngeal mask airway. Okay. Again, if there is difficult intubation, we can use that LMA. Then this is nasopharyngeal airway. Okay. And this one is Goodell's airway or oropharyngeal airway. Clear? So, these are the different equipments which you should know. Goodell's airway, nasopharyngeal is not that important. Laryngeal mask airway is very important, and obviously endotracheal tube. You can see a cuff here, right? So, this is the endotracheal tube. Obviously, it will be used for endotracheal intubation. Then there was a new question from radiology, and it was about safety principle LRA. Full form of radiation safety principle LRA. Now, as the name suggests or as the term suggests, there is something about radiation safety of the personals who are working in the radiation department, radiology department, or even the patient, and this actually depends on three things. One is the timing, right? Then second is the duration, and the third one is the shielding. So, this is how we can ensure safety of the personals who are working in the radiology setup. So, one is timing, like minimize the time as much as possible, minimize the time of exposure. Clear? So, whenever doing an X-ray, minimize the time. Then this is what duration we already discussed, okay, and then another is distance, right. So, keep the distance more as much as possible. So, stay away from that field as much as possible. And thirdly, use lead aprons, right. So, shielding means protection. So, use lead aprons. So, these are few things which you should know. So, this timing is duration, of course. So, timing or duration, so keep it less as much as possible. Then shielding must, and distance, maintain adequate distance from the radiation exposure area. So, this all suggests that we have to keep the radiation exposure as low as possible, right. So, as low as reasonably achievable, where the radiation exposure is less, right. So, the motive is radiation exposure is less, but at the same time the investigation is nicely done. Clear? So, it should not happen that we are minimizing the radiation exposure, but the quality of the investigation is very poor. So, that should not happen. There should be a balance. The investigation should be nicely done, keeping the concept of minimizing the radiation exposure to the patient and also to the personnel working in the radiology department. So, that is the safety principle, radiation safety principle LRA, as low as reasonably achievable. Okay, so, this was a new question this time. Then next question, an adult and responsive patient is choking while swallowing and has complete airway obstruction due to a foreign body. What is the most appropriate emergency maneuver? Now, this question has been repeated many number of times, and I think most of you can answer it the moment you read the question. So, that's very easy. So, here what is being given? The patient is adult, responsive, then choking, and there is foreign body swallowing. Okay. So, what we need to do in cases of adult who are responsive with foreign body, we have to do the Heimlich maneuver. Okay. So, we have to do the Heimlich maneuver where we hold the patient from the behind, and then we give a epigastric push, and this creates a pressure so as to propel the foreign body outward. So, that is Heimlich maneuver, very favorite for exam setters. So, Heimlich maneuver for foreign body ingestion in adults who are responsive. Clear? So, that is very important. Adult is very important here. Chalo, next question. A 30-year-old male presents with 3 hypopigment anesthetic patch, thickened radial nerve, and loss of sensation over both the hands and feet. Culture was negative. Slit skin smear from earlobe and lesion shows acid-fast bacilli with bacteriological index of 4+, and then a diagnosis of multibacillary leprosy was made. Now, what has to be given to this patient? So, here, although the diagnosis has been written in the question, but still we should know the keywords in case if the diagnosis is not given any time later. So, there are 3 hypopigmented anesthetic patches. Clear? Then there is thickened radial nerve, then loss of sensations, then culture negative, slit skin smear, 4+ bacteriological index, and this particular goes in favor of multibacillary leprosy. Clear? MBT, right? So, multibacillary leprosy. Now, what we need to do here? This is already given to us like multibacillary leprosy, and here there is one more important point. Culture is negative, and we know that leprosy bacilli can't be cultured. And if you have discussed about Robert Koch's phenomena, postulate, like this is the one bacteria which does not fulfill Robert Koch's postulate because it cannot be cultured, although it can be grown on footpad of mice or 9-branded armadillo. Okay, so this is very classical, multiple lesions and then loss of sensations. This is multibacillary. Now, for multibacillary, what we need to give? We have to give multi-drug therapy. And how many drugs we need to give here? We need to give rifampicin, then dapsone, and what is the third one? Clofazimine. Clear? So, clofazimine. This is 600 mg. Okay. This is 100 mg daily, and this is 300 mg once monthly. And this all has to be given for how much period? For 12 months, and it should be completed within 18 months, isn't it? So, this is the treatment plan for multibacillary leprosy. Clear? So, this was the question. like you should know the doses and the way of giving, like rifampicin is supervised, clofazimine is supervised. Okay, so this was a classical question for multibacillary leprosy. Then there was a CT image, and this is the one which is repeated almost every year in every exam, and I think no one can do it wrong. So what here you see, you are seeing a biconvex hyperdense lesion, right? So you can see biconvex. So this is like this, one side this, right? So this is known as biconvex, and this is hyperdense lesion, looking more white on CT scan. So this is classical for extra or epidural hemorrhage. Clear? It is classical for extra or epidural hemorrhage, and I think most of you, yes, oh, nice to see you, Meet Bhai, really very good, very good. So this is, yes, this is classically, the source is arterial, and this is middle meningeal artery. Clear? So sometimes we can see the fracture around the pterion as well, but this is what you need to remember. So take this image like a lemon shaped hyperdense lesion. Okay, so this is hyperdense lesion. Clear? So this is the classical extradural hemorrhage, and this is the hot favorite for exam setters. Then there was one question again from ortho, and here a 24-year-old male brought to the emergency department after a road traffic accident. There is a closed fracture shaft of femur which was managed initially with splinting. Then 48 hours later he developed sudden breathlessness, tachypnea, confusion and fever. On examination, saturation was low, 84%, and there were multiple petechial rashes on the upper chest and axilla. Then bilateral crackles on auscultation, and there are diffuse bilateral fluffy infiltrates. Very good. So very good, Meet Bhai, absolutely right. So just to note down few keywords which are essential to make a diagnosis of fat embolism syndrome. Obviously this is a case of fat embolism. Now what you need to know here, one important thing is time duration. So the symptoms, they usually come around 48 to 72 hours. Then there will be fracture of shaft of long bones, and as in the given case it is femur here, right? Sometimes there can be multi-trauma, so that also increases the possibility of fat embolism. So multiple bones fractured at the same time, and there is a mnemonic to remember the manifestations. You can remember it as with the word PNR. So P is for petechial rashes, right? N is for neurological signs or manifestations, and R is for respiratory signs or respiratory manifestations, right? So this PNR will help you. So petechial rashes, they are seen over the upper chest, axilla, sometimes in conjunctiva. Then neurological, you can see that the patient is confused, right? So neurological, we can see that the patient is confused. Then respiratory, we can see there is dyspnea and there is tachypnea. Clear? So we can see there is breathlessness, there is tachypnea. So this is very good, very good. So this is a classical case for fat embolism, and this is one of the favorites every time we get to have a question like this, right? So this is how you can look for those clues, and you can reach up to your answer. Then this is one question which we have already discussed in the previous session yesterday. So here the male thinks that his wife is secretly watching him through the hidden camera and plotting to harm him, and then therefore he has avoided going outside, speaking to himself at times, and has become socially withdrawn. Then there is no history of any drug or substance abuse. Then there is firm, fixed, false belief which is not correctable even after giving reasons to that. So what is the initial management? So here what we discussed yesterday, like certain keywords, I will just note it down in case some people has joined us newly, right here. So there is one, delusion of persecution. Clear? So delusion of persecution, very good, meet bhai, very good. So somebody is planning to harm. So this is delusion of persecution. Then the patient is become socially withdrawn, right? And there is one more term like speaking to himself. So this is all going in favor of schizophrenia, and since it is a psychosis, it is a psychotic condition, so we should start the patient on antipsychotics. Clear? So this is a psychosis, so patient should be started on antipsychotic like olanzapine. So this is classical. So delusion of persecution, the moment you find this word, straight away you can think of schizophrenia, and then antipsychotic as a part of treatment. Then a pregnant lady is diagnosed as multibacillary leprosy. Now, yes, very good, meet atypical first. Yes, atypical, we can write atypical here. Atypical because they have less extra pyramidal side effects. Okay, so they have less extrapyramidal side effects, so therefore prefer atypical antipsychotics. Very good. Now if a lady is diagnosed with multibacillary leprosy, what should be the approach for treatment? So remember here, if a lady is pregnant, still you need to continue the standard multi-drug therapy, right? So the standard treatment of leprosy for multibacillary leprosy has to be continued even in pregnant state. So pregnancy is not a contraindication, or pregnancy should not defer you from starting MDT, okay, multi-drug therapy. So the way a normal fellow is given multi-drug therapy, similarly you need to continue, you need to start the treatment in pregnancy as well. So there is no change at all despite pregnancy. Now a 14 years old child came with neglected congenital talipes equinovarus. So this is congenital talipes equinovarus, or what you call club foot, because the foot resembles a golf stick. So it looks like a golf stick. Okay. So now specifically they have been given 14 years, and sometimes what happens whenever we are into clinical practice, we see many adults patients, they are coming with neglected or untreated CTV, and the whole sole purpose is to get disability certificate, so they can have some relaxations or some privileges, right? So if you see a fellow who is of 14 years, then here conservative treatment won't work. So conservative treatment won't work. So it means there is no role of cast treatment. That is the Ponseti method, which is the prevalent method nowadays. Very good, Meet Patel, very good. So if the age is more than say 12 years, what we need to do? We have to go for triple arthrodesis. So, what is this word? Triple means obviously 3, arthro means joints, and desis means surgical fusion. So, we are doing surgery and we are fusing those 3 joints. Very good, Meet Patel. So, beyond 12 years, go for triple arthrodesis. Now, the question is, what are the 3 joints here? We are saying that we need to fuse the 3 joints. So, one is, if we write the bones like this, right. So, then here is cuboid, and in front of talus is navicular. Okay. So, this is one talonavicular joint, fuse it. Then this is second talocalcaneal, fuse it, and the third one is the calcaneocuboid, right. So, we are fusing 3 joints, talonavicular, subtalar and calcaneocuboid. Okay. So, these 3 joints are fused. Now, remember, now what you need to remember here, do not fuse ankle joint. Okay. Ankle joint is not involved, so do not fuse ankle joint. So, many times this is an all except question, and most likely the answer would be ankle joint, because that is not touched at all. Now, this is one image I kept, like I just want to show you what are the bones which we need to fuse. So, this is the calcaneum here, this is cuboid, this is navicular, and this is the talus, right. So, fuse talus and navicular, fuse talus and calcaneum, and fuse calcaneum and cuboid, right. So, what we need to do? We need to remove the articular cartilage, we need to expose the raw bone, and then we need to pass the screws so as to approximate the 2 bones and leave the implants till there is bony union. So, this is triple arthrodesis, clear. So, this word is very important, triple arthrodesis. Now, arthrodesis should not be confused with the ankylosis word. There is one word, ankylosis, because many times if you have read about say a TB of spine or TB of peripheral joint, there is, you find the word ankylosis. So, ankylosis also means fusion, but that occurs because of disease process, right. So, it is occurring itself as a outcome or a sequelae of a disease process, but in arthrodesis we are doing it. So, that is surgical. So, that is the, although the meaning is somewhat same, arthrodesis, ankylosis, the joint is fused, but the approach is different. Then there was one question where the patient is presenting with intense itching, especially at the night time. He has, now in this image it was a lesion which is shown over the scrotum, and he lives in a crowded environment. Now, you have to identify the condition, and not related to this particular image, you have to think of the primary lesion of the condition per se. So, here there is a classical keyword, that is intense itching, and this is worse at night. Supportive can be like living in crowded environment and involving genitalia, it's all supportive. But the classical is intense itching, more at night. The moment you find this word, you should always think of, very good, Meet. Yes, this is classical condition which is in discussion is scabies, and you need not take the answer from this particular image, because here we are not seeing any burrows. So, primary lesion of scabies is burrows. which is principally seen over the web spaces or interdigital cleft, right? But in this particular image, we can see some nodular lesions. Okay, so not classical burrows here. So we can see some nodular lesions. So this is how you should approach this question, and I think this image is given just to confuse, because if you go with the image, you will never reach up to the right answer. So you have to think in the broader aspect of the condition, and the primary lesion is burrow. So very good meet. Now there was again one new question about polycystic ovarian syndrome, and it was like asked like what are the diagnostic criteria on the transvaginal sonogram. So I think it's just like you need to just memorize it. Like the very first thing is that very good meet, very good. So it should involve at least one ovary. So out of the two, it should involve at least one. And then what we need to see, that there should be at least 20 follicles, right? And there should be at least 20 follicles, and the size should be around 2 to 9 millimeter. And this may be or may not be associated with ovarian volume more than 10 milliliter. So this is and or. So either of the two is also acceptable, right? So suppose if we write the two conditions like more than 20 follicles, right, at least in one ovary, right? So at least in one ovary, and the size should be 2 to 9 mm. And then another is ovarian volume more than 10 ml. So if only this is present, say if only this is present, you will label the patient as PCOS. If only this is present, still you will label the patient as PCOS. And if both are present, nothing better than that. So it's like plus or oblique. Either of the two, both, that's okay. So there should be at least 20 follicles involving at least one ovary, the size around 2 to 9 mm, or the ovarian volume more than 10 ml. And I think most of you must be knowing what we see on the transvaginal ultrasonography scan for polycystic ovarian disease. We will see multiple follicles arranged at the periphery, right? So peripheral arrangement, and because of these peripheral arrangements, it gives a necklace arrangement. Clear? So that's, I think, very basic. Now there was a video based question, and this was from a very important topic in anesthesia. So the patient was asked to open the mouth fully and protrude the tongue, no need to speak anything, and this was the final picture of that video. So based on this, students were supposed to tell the Mallampati class. Now based on this image, what you think is the Mallampati class for this particular case? So I think most of you must be knowing what is the purpose of doing Mallampati grading, and I think most of you must be knowing that Sheshagiri Mallampati was an Indian, right? So this is something given by an Indian, so a little bit something to be proud of. So Mallampati grading, and this is done to assess the ease of intubation. So if we are planning to intubate the patient, so we should have a initial idea like whether it will be a easy or whether it will be a tough task. So what you can see here, now although if you go for description, there will be like many things, this and that, but I'll just try to simplify it. The only thing which you need to look is uvula. Okay, So, the only thing you need to focus on is uvula. Now, if we look here in the midline, this hanging thing is uvula. Okay. So, for uvula you can like you can do it, you can remember it like this, and then right. So, this is the base of uvula, this is you can say body or portion of uvula, and this is the tip of uvula. Okay. So, you need to look at the uvula, like how much part you are able to see. Now, suppose if we look at this particular image, here we can see the tip, we can see the part or body, and we can see the base also. And if you can see this all much, it means the patient is very comfortable in opening the mouth, and this is class 1, right. So, in class 1 we can see the tip of uvula. Now, suppose if we can see only this much part, we cannot see the tip. So, that will be class 2. So, in class we will see the you can say body of uvula, but not tip, right. So, tip is not visualized. Now, suppose if the patient opens the mouth and we can see only this much, we can see only the base, then it is class 3. So, in class 3 we can see only the base of uvula, nor body nor tip. Okay. So, if we can see all these 3, this is class 1. If we see only 2, this is class 2. If we see only this base, this is class 3, and if we see nothing of uvula, right, nothing of uvula, class 4. And here what we will be seeing? We will be seeing only hard palate. Clear? So, this is a simpler version of remembering the Mallampati classes. If everything seen, class 1, if tip not seen, class 2, if only base seen, class 3, if nothing seen, class 4, like that. Okay. So, I felt that that video was shooted on a normal person, and therefore, the grading was class 1. So, like that. Then a 25-year-old sexually active male presented with a ulcer followed by a swelling in the inguinal region. On examination, there is enlargement of both the inguinal and the femoral lymph nodes separated by the inguinal ligament, producing a classical groove sign. Now, everything is given here. So, you need to tell me the causative agent. So, again let me write the keywords for you first, because sometimes we do not have everything given in the question, right. So, we have to derive like what is the condition, then what is being asked. So, here there was a genital ulcer followed by swelling in the inguinal region, and then there is enlargement of both inguinal and the femoral lymph nodes, right. So, that is the classical groove sign, and yes, if someone can answer it, it is not that difficult. So, it is the classical groove sign. So, this classical groove sign is seen in lymphogranuloma venerum, LGV. What is the causative agent for LGV? This is chlamydia trachomatis. Clear? So, this is chlamydia trachomatis. Very good, Kakul. So, this is LGV caused by chlamydia trachomatis, and here you can see the classical groove sign. Now, this is the inguinal lymph node, and this is the femoral lymph node. Okay. So, you can see on the upside this is inguinal. So, this is inguinal lymph node which is enlarged, this is femoral lymph node which is enlarged, and the area, and this area is converted into a groove, right. So, this area is converted into a groove. So, it is known as the groove sign, and this area is actually occupied by the inguinal ligament, right. So, here what is there? This is all inguinal ligament. So, this is inguinal ligament territory. So, this is the classical groove sign of LGV caused by chlamydia trachomatis. Now, remember here there is one more condition which causes pseudo groove sign, means it looks like a groove, but it is not the true groove. So, this is seen in donovenosis. Okay. So, just make sure you do not fall into this trap, pseudo groove, donovenosis. And in LGV, this genital ulcer is very transient, and most of the time the patient even does not notice it. Okay. So, therefore, it mainly comes as enlargement of lymph node, and that is buboes. Okay. So, classical LGV picture, classical groove sign has been asked many number of times. Then there was a question. Now, this is something like INI CET pattern, where they give match the following kind of questions. Like, so here on one side they have given some investigations, right. So, these are the investigations on one side, and on other side the images were given, and we need to match the modalities with the images. Clear? So, this is the modality and this is the image. So, now we will go one by one. ERCP. Now, can you think which one looks like ERCP, whether A, B, C or D? Which one is the ERCP? So, let me write few words about ERCP first. If you know the full form of ERCP, you will get the answer. So, E for endoscopic, R for retrograde, and CP is actually cholangio pancreaticography. Clear? So, what we are doing, we are passing a endoscope. So, we are passing an endoscope, and then we are going backward to study the bile ducts and the pancreatic duct. So, endoscopic, retrograde, cholangiopancreatography. Now, here the word is endoscopic. So, in which image, A, B, C or D, you can see an endoscope. If you can look the impression of endoscope, that image is obviously of ERCP. So, if we look, this is the endoscope. Clear? So, this is the endoscope, and then if you see here, this is the common bile duct like this, right. So, this is the common bile duct. So, this investigation is ERCP, endoscopic retrograde cholangiopancreatography. Okay. So, this is how you need to identify, very easy to identify. This instrument is endoscope. It is going till duodenum, and through the major duodenal papilla we can study the duct system of the common bile duct, the hepatobiliary duct and the pancreatic duct. Now, let us take the second investigation, MRCP. Now, obviously from A, B, C you have to choose MRCP. So, let me write the full form of MRCP first, then it will be very easy for you to understand. So, M is magnetic, R is resonance, and CP is obviously the one we have, cholangiopancreatography. So, now from ABC, which one looks MRI to you? So, this one is MRCP. Okay. So, here it is a T2 weighted MRI. Clear? So, here is a T2 weighted MRI, and in T2 the fluid appears white. So, very easy to identify, and the advantage of MRCP is that there is no radiation exposure because it is MRI. So, no radiation exposure, it is non-invasive. Clear? We need not do any puncture. So, this is MRCP. Then third is HIDA scan. Now, HIDA scan is a radionuclide study where we evaluate the biliary passage. So, this is the HIDA scan, and this is very valuable for conditions like biliary atresia. Okay, so, this is HIDA scan, and this is radionuclide study. And the last one is percutaneous transhepatic cholangiography, PTC. So, P means percutaneous, T is transhepatic, and C is again cholangiography. Clear? So, now percutaneous. Percutaneous means what? Through skin, right? Just like we are giving an injection. So, through skin. Transhepatic means through liver. So, what we do? We pass the catheter through the skin, through the liver into one of the ducts, and then we study the ductal system. So, this is percutaneous transhepatic cholangiography. Clear? So, this is how we need to do it. So, these are some investigations which you should know, and even not more detail, but at least how to identify them. Okay. So, this is MRCP. Okay. So, this one is MRCP, this is HIDA scan, this is percutaneous transhepatic cholangiography, and this is ERCP. Then moving forward to next question. Okay, this is how the percutaneous transhepatic cholangiography is done. So, we pass a needle through the skin, through the liver, and into the biliary duct. Okay, and then we pass the dye to study the biliary duct. Now, next question, a test was done on a patient and it came out to be positive. Which nerve is likely to be paralyzed? So, firstly we have to identify which test is this. Now, look here, what is being given to the patient? It is a card, right. So, card is placed between fingers, right, and we tell the patient, okay, you try to do finger adduction or you try to resist, I am trying to pull the card. So, this is known as card test. Now, if the patient is having a good adduction of fingers, then it is very difficult to remove the card. But if adduction is gone, then card can be easily pulled, right. So, now, what are the muscles which are causing adduction of fingers? So, these are actually palmar interossei. So, it means if the palmar interossei are paralyzed, the parent nerve is paralyzed. So, this is one card test which is done for checking palmar interossei muscles which are supplied by ulnar nerve. So, ultimately we are checking very good SNV Prasad palmar interossei, very good, right. So, in card test we are checking palmar interossei. If we can easily remove the card, it means palmar interossei are paralyzed. Yes, SNV Prasad, this ulnar nerve. Chalo, next question. Treatment of choice for the given condition. Now, look here, this is a coronal section MRI, And what we can see here, there is, now this all is involvement of the turbinates, and this is known as the black turbinate sign. Okay, so here you can see the black turbinate sign, and this black turbinate sign is suggestive of invasive mucormycosis. Okay, very good SNV Prasad, very good, mucormycosis. And yes, we need to give liposomal amphotericin B, very good. Yes, in short you can write LAMB, very good. So liposomal amphotericin B, clear. So this is invasive mucormycosis. Very good, gentlemen, very good. Then next question, a 4-year-old child presented with fever, painful ulcers and vesicular lesions over the palm and soles, and this is the image which was given. I think very diagnostic image the moment you look at this. So child with vesicular lesions, very good. And look where they are present: palm, sole and mouth. Very good, SNV Prasad. So palm is hand, sole is foot, and this is mouth. So this is how you will get to your condition, hand, foot and mouth disease, which is, yes, caused by Coxsackie A16 virus, right? So this is clear. So hand, foot and mouth disease. So very easy to identify. Or enterovirus, yes, very good, also by enterovirus. Now next question, a 4-year-old boy is brought by his parents with concerns that the child does not respond when called by name. He avoids eye contact. He is okay in studies but has problem in making friends. He prefers playing alone and shows no interest in interacting with other children. He repeatedly flaps his hand and becomes excited when he is excited, and becomes distressed if somebody tries to change his daily routine. Speech is delayed and often repeats the word spoken by others. What is the condition in discussion? Very good, SNV Prasad. Yes, this is a classical case of autism spectrum disorder. So here there are some clues like 4 years old boy, right? And then doesn't listen, like therefore presumed to be deaf. Kakul, absolutely right. Then avoids eye contact, then prefers playing alone, okay, no social interaction. So plenty of keywords in this question, and this is a classical description for autism distress, autism spectrum disorder, right? So speech is delayed, and then there is echolalia. It means he will repeat the words whatever he is listening from others. So classical autism spectrum disorder. And very hand flapping, yes, very good. And he has a fixed daily routine. He don't like to have any change in that. If you do any change, he will become distress. So plenty of keywords and the classical description for autism. Very good, SNV Prasad. Chalo. Then OK sign is performed to check functioning of which nerve? OK sign. Now this is the OK sign. If you see here, if we are doing this kind of maneuver, we are checking which nerve. OK sign. Now here I just give you two clues, like what we are checking here. We are checking flexion at PIP, index finger, okay, and we are checking flexion at IP joint of thumb. Clear? So we are checking flexion at PIP of index finger and we are checking flexion at IP. Now this is brought by flexor pollicis longus and this is brought by flexor digitorum superficialis, and both are supplied by anterior introitious nerve. So if look here, this is flexion at PIP, and look here, this is flexion at IP of thumb. So if the patient can do a proper OK sign, it means his anterior introitious nerve is working nicely. And yes, anterior introitious nerve is actually a branch of median nerve. So if there is no anterior introitious nerve in the options, you can go with the parent nerve, but exactly it is anterior introitious nerve. Now suppose if the anterior introitious nerve is paralyzed, very good SNV Prasad, what will happen? The patient will not be able to make a OK sign. So suppose if AIN is paralyzed, OK sign is not possible. And then what patient will do? He will make a pinch sign, because the index finger will be extended at PIP and the thumb will be extended at IP. So it will become something like a pinch sign. So this is how we can check anterior introitious nerve, more specifically a branch of median nerve. Then moving forward to next question, a male presents with asymptomatic brownish patch in the upper thigh for past 4 months and wood lamp is showing coral red color. What is the treatment? Now here firstly we need to identify the condition. So there is a asymptomatic brownish patch in upper thigh, and the classical help is in the form of wood lamp examination, and what is shown in the wood lamp? Coral red color. So I think very good SNV Prasad. So here you can see this is the coral red color which is shown by the lesion. Okay, so this is classical of which condition? This is classical of erythrasma, and erythrasma is a bacterial entity caused by Corynebacterium minutissimum. Okay, so obviously if it is a bacteria you need to give antibacterial. Very good. So we need to give antibacterial, that is erythromycin. Wonderful. So this is erythrasma and it is asked many number of times. So very favorite. Then advantage of brachytherapy. Brachytherapy means source of radiation is placed close to the patient, right? So what is the advantage of keeping the source of radiation close to the patient? Minimize damage to the nearby normal tissue. Okay, so it means we just want to make sure that the radiation dose is given to the tumor area only and not to the normal tissue, because there will be damage to the normal tissue also. So by keeping the source of radiation close to the patient, we can minimize the radiation damage which is occurring to the very good SNV Prasad, radiation to only tumor, less radiation to the surrounding normal part. Very good. That's the advantage of brachytherapy. Now next question. A male has a deep laceration on the medial aspect of his wrist while working with a glass sheet, and then later on he has weakness of hand grip and difficulty spreading and bringing together the fingers. There is wasting of interossei and therefore he cannot abduct or adduct the fingers, and there is sensory loss over the little finger and the medial half of the ring finger. Now what nerve injury you can think here? So here there is injury onto the medial aspect of the wrist. So injury to the medial aspect of wrist, and after this there is some nerve injury. Now what is happening? Weak hand grip, then wasting of interossei, okay, then no abduction or adduction of fingers, and lastly there is sensory loss over the little and medial half ring finger. Classical word. Look at the sensory loss. This is little finger and medial half of ring finger. So this is 1.5 volar medial side. Then interossei are gone, so no abduction, no adduction of fingers. Very good, Kakul. So we know that these all are supplied by ulnar nerve. So this is a case of ulnar nerve injury. So again this territory is of ulnar nerve. So if there is any question which says that on the volar aspect or the palmar aspect there is any sensory loss involving the little finger and the medial half of the ring finger, the answer has to be ulnar nerve. Very good. Chalo. A patient with bipolar disorder is on treatment with some drug. Now he is having excessive thirst and polyuria. So bipolar disorder. Now why we call it bipolar? Because sometimes the patient is overexcited, that is mania, and sometimes the patient is very sad, that is depression. So this is known as bipolar. So it's a kind of mood disorder, right? What is this? Mood disorder. The patient is not neutral, sometimes he is too happy, sometimes he is too sad. So this is bipolar disorder. We have to start him on some medication, and this medication results in excessive thirst. Excessive thirst is what? Polydipsia, right? Drinking too much of water. And polyuria means large volume of urine. So he is drinking more water and he is passing more water in urine. Now this condition is diabetes insipidus, right? What is this known as? Diabetes insipidus. Yes, polydipsia, absolutely right. So this condition is diabetes insipidus. Now which medicine can result in diabetes insipidus? And this medicine is actually lithium. Okay, so this medicine is lithium, and since it is affecting on the kidney, so this type of diabetes insipidus is known as nephrogenic diabetes insipidus. Okay, so this is nephrogenic diabetes insipidus, which is one of the important complication of lithium, which is given for bipolar disorder, right? So this is how you need to solve this kind of question, right? So bipolar disorder, lithium, nephrogenic diabetes insipidus, because what happens, the lithium, it makes the aquaporin receptors within the kidney, they are resistant to antidiuretic hormone. So despite having normal ADH, patient will pass large amount of urine. Chalo. Next question from anesthesia. There is a patient of road traffic accident and the BP is 80/60. Now which anesthetic agent you will prefer in such case? Because here this patient is having hypotension, BP is less. So obviously we will prefer an anesthetic agent which will have an effect of increasing blood pressure. Now which agent is that? This is ketamine. Okay, so ketamine is the agent of choice in hypotension because it increases blood pressure. So it increases the sympathetic tone and it increases blood pressure. Thank you, SNV Prasad. Yes, gentlemen, and the way you are answering, I am really impressed, and that shows that you are definitely a step ahead. Very good. God bless you. Keep on preparing, bache, keep on preparing. Right? So this is ketamine, which should be preferred. Okay, yeah, definitely. Why not? You can just drop me a WhatsApp message and I'll just customize some study plan for you. Don't worry, okay? I'll help you, don't worry. Right? So for hypertensive patient, prefer ketamine because it increases blood pressure. Right? Chalo. Now, what is the causative agent for head, foot and mouth disease? We already discussed previously. This is classically in your exam, Coxsackie A16 virus. This we already discussed, right? So no need to. Now, Froment sign is positive in injury to which nerve? Froment sign is positive in injury to which nerve? Now, this is also one of the very favorite topics and it has been repeated many number of times. Froment sign. Now, this is also known as book test. Clear? This is also known as book test, and what we do actually, we keep a book in first web space. Clear? And we check adduction of thumb. Now, adduction of thumb, it is done by adductor pollicis. And what is the nerve supply of adductor pollicis? It is ulnar nerve. Now, if the ulnar nerve is okay, the patient will keep the thumb like this. So, adduction is possible. So, the thumb will be like this. Now, if the ulnar nerve is gone and if we try to remove this book from this area, the patient will resist by bending the thumb. Right? So, if adductor is gone, the patient will bend the thumb to hold the book, and this bending of the thumb is done by a different muscle, flexor pollicis longus, and we already discussed what is the nerve supply of flexor pollicis longus. This is AIN, which is a branch of median nerve. So, these are some clinical tests, like we check for certain muscles, and by the way of those muscles we are actually checking the nerve supply of those muscles. And here this adduction by ulnar nerve and flexion by median nerve. So, that is the difference in this Froment sign, also known as book test. Right? Previously we discussed card test, now this is book test. Chalo. A patient has intense fear of having cancer after his uncle died from it. He repeatedly visits doctor and undergoes investigation. Despite repeated assurance that all reports are normal, he remains convinced that he has some serious illness. Now, what is this diagnosis? I think it's a very classical case. There is a intense fear of having cancer because already there is an episode. Then he will repeatedly visiting doctors. All reports normal, right? And reassurance given. But despite that, patient thinks that I am having cancer. Right? So, despite that, the patient is thinking of having the disease. Now, what is this? This is classical hypochondriasis. Okay? So, illness, anxiety disorder. What is this condition? Hypochondriasis, which is also known as illness, anxiety disorder. Patient is absolutely normal. All reports are normal. Clinical examination, everything normal. Doctor is telling, see, you are absolutely fine. Don't think about it. But still, patient feels that I am having the disease because my uncle died of that disease. So, this is hypochondriasis or illness, anxiety disorder. Now, what is the principle of the modality? So, firstly, you need to identify which modality is this. So, here in the image you can see a colorful picture. So, any idea what is this? So, here there are two components actually. So, of this investigation, one is metabolic functioning and second is anatomical image, right. So, here we see two things. One is anatomy, which is represented by CT scan, and the functioning is by PET, that is positron emission tomography, right. So, this is two investigation in one. So, the white is all bone and this is all nicely shown in CT scan, and the colorful what you see is all PET. So, this is a classical PET CT scan, right. So, CT is giving you an anatomical image and here you can see the bones are very white. So, that is all CT part, and then PET is all colorful part. So, that is yes, it is a transfer section and this is investigation is PET CT scan. Now, in PET CT scan, especially in PET scan, what we do, this is positron emission tomography. PET means positron emission tomography. So, this is a kind of radio tracer study, and what happens here, we give fluorodeoxyglucose. Okay. So, 18F fluorodeoxyglucose, and what we do here, we are giving a radionucleotide glucose. So, this is fluorodeoxyglucose. Now, what happens, this glucose is taken up by cells which are more active, like cancer cells or inflammatory cells. Clear? So, malignant cells or inflammatory cells. So, therefore, this investigation is very valuable for studying malignancy. It can be used for brain or heart as well, but very valuable for malignant conditions or inflammatory conditions. And we give 18F FDG, fluorodeoxyglucose, which is a type of glucose, radioactive glucose, which is taken up by the cancer cells or the inflammatory cells, and then the picture is created with the help of emission of positrons from those tissue. So, that is in this what is happening, there is increased uptake of glucose, and obviously the glucose here we are giving is radioactive glucose by either the malignant cells or the inflammatory cells, right. So what you need to remember, increased uptake of glucose, increased uptake of glucose, and how it is provided in the form of FDG. So in FDG what is used, in PET scan what is used, FDG, right. So this is PET CT which is shown here. Then next question, a non-case of borderline leprosy, like borderline tuberculosis, borderline or borderline lepromatous, he is on multi-drug therapy. Now what happened during the course of therapy, that there is redness and swelling of the existing skin lesions, and this is associated with pain and tenderness of the peripheral nerves too. Now what we need to do here, so let us write the keywords here. Patient is a known case of borderline leprosy, clear, borderline leprosy. Then the patient is started on multi-drug therapy for leprosy. Then what happened, the existing lesions, whatever the skin lesions were there at that moment of time, they developed redness and swelling. So the classical keyword is that there is change in the existing lesion, there are no new lesion. So this type of reaction is known as lepra reaction. The patient is taking the drug and the reaction is occurring, it is known as lepra reaction, and if it is involving only the existing lesion, it is known as lepra reaction 1. So this is a classical case of lepra reaction 1, which is type 4 hypersensitivity reaction. It's type 4 hypersensitivity reaction, and what you need to do here, see, lepra reaction is bound to happen during the course of MDTP. So it does not mean that you stop, it is not a drug reaction. So you need to continue multi-drug therapy. So continue the treatment of leprosy, plus what you can do, you can add steroids, right. So just add steroid to the already undergoing MDT. Yes, so Kakul, MDT plus steroid. So MDT has to be continued. Apart from this, you need to give steroid. So this is the treatment of lepra reaction 1, right. And in lepra reaction 1, the classical feature is that the existing lesions will undergo some change. There will be no new lesions. That's how we define lepra reaction 1. Chalo, next question. A patient has chronic pain in the right buttock and groin that worsens while climbing stairs and getting out of the car. On examination, the patient hip is in flexion, abduction and external rotation. So there is a test where flexion is done, abduction is done and external rotation is done. So this is the name of the test, and this test is known as the Faber test. Okay, so this test is known as Faber test, and what the doctor is doing here, and then he is giving a pressure on the flexed knee, and this produces a pain on sacroiliac joint. So what we do, we keep the limb in this attitude, and then we put the pressure on the knee, and we look for the site of pain. If it is over the SI joint, as in this case sacroiliac joint, this is a case of sacroiliitis, right. So there is inflammation of the sacroiliac joint. Sometimes the pain can be over the hip region, then it means there is pathology of the hip joint, right. So this Faber test actually helps us in differentiating whether the problem is within the sacroiliac joint or the hip joint. So this is how you need to differentiate. So the patient will be kept in flexion, abduction, external rotation, and resting the ankle over the opposite knee, then gentle pressure over the flexed knee downwards, and look for the site of pain, whether it is over the sacroiliac region or over the hip region, and that will help you in reaching up to the diagnosis. In this particular case, it is sacroiliitis. Then now this is one very new question which has, although it has been asked in NEET PG, but for the first time it has been given in FMGE. A patient presents with a linear depressed lesion over the scalp and there is localized alopecia. Now alopecia means loss of hairs. So there is a linear depressed lesion, and this is also known as linear morphia. So this, if you look here, it looks as if this much area has been hit by a sword, right? So you can see there is alopecia, there are no hairs in this particular area, no hairs at all. So this is alopecia, and linear means just like in a straight line like this. So linear lesion with alopecia, looking like as if the injury has been inflicted by a sword. This is Ancoub saber, right? So saber means sword. So the injury has been like by a sword. So this is Ancoub saber. Then there was a video based question in which the patient was unable to dorsiflex the wrist, and what is this condition? I think everyone can answer that this is classical wrist drop image. And what is the reason for this? Which nerve paralysis? This is the paralysis of radial nerve. Okay, and at what location? Like fracture shaft humerus. Clear? So there is paralysis of the extensors of the wrist joint. So this is the classical wrist drop, and it is one of the hot favorites for exam setters. Every year they will give you. So the patient is not able to take the hand like this. So dorsiflexion is not possible. Okay. Then next question. A school teacher is in depression as she believes that all her students are failing in exam because of her poor teaching. This is for 2 months, but she also hears voices which are commenting on her actions. What is the best treatment? Now here you have to understand what is the condition, then only you can think of the treatment, and it is very easy to correlate. Now look here, the school teacher is in depression, or you can say low mood. Why? Because she thinks that students are failing as she is not teaching them properly. So, okay, so this is one thing. So here she is having a depressive component, but at the same time she is also having one more problem, and she is hearing voices commenting on her action. Now this is like third person auditory hallucinations, right? So the patient will hear voices, and the voices are talking about the patient. So this is hallucination. Now hallucination means no stimulus. It means no one is talking, but perception is present, but the patient is hearing the voices. So this is auditory hallucination. So third person auditory hallucination, and this is classical of schizophrenia, which is a psychotic disorder as we discussed before, right? So there are two problems going on in the patient. One is schizophrenia and second is depression. Now depression is discussed under mood disorder. The mood is low, and mood is also known as affect, right? Please remember, this is affect and not effect, affect. So if we take these two words, so we can take schizophrenia from here and we can take affect from here. So this condition becomes schizoaffective disorder, right? So this is the nomenclature of this condition, schizoaffective disorder. So here the patient has features of schizophrenia, third person auditory hallucination. The patient has features of depression, which is affect or mood disorder. So it's a combined schizoaffective disorder. Now when we have to treat such patient, we have to give treatment for both. So we have to give treatment for this, we have to give treatment for this. In one of the previous question, I told you what we need to give for schizophrenia, antipsychotic, right? For schizophrenia we need to give antipsychotic, and for depression we need to give antidepressant. Clear? So in this patient we need to give both the drugs, antidepressant plus antipsychotic. So for schizoaffective disorder, the treatment is antidepressant plus antipsychotic. Is that clear? Very easy to understand if you can understand the basic presentation of the patient. Very easy to answer. Then next question, a patient has cauliflower-like growth over the genital region, causative agent. Now cauliflower growth, especially say if it is a female, it can be vulva, and this is classical of condyloma acuminata. Clear? And this is also known as genital warts. Now what is the agent for genital warts? The agent for genital wart is human papilloma virus. So human papilloma virus 6 and 11 for genital warts or condyloma acuminata. This is very important, acuminata. Then next question, a patient was on warfarin therapy, okay, anticoagulant warfarin. Now the patient has been planned for surgery. So obviously when you are taking the patient for surgery, the anticoagulant has to be, the course has to be modified. So what we do actually for warfarin, we have to stop it around 4 to 5 days before surgery, right? So suppose if the patient is planned for surgery on 30th, we will stop the warfarin on 25th, and instead of warfarin we can start the patient on low molecular weight heparin, right? So substitute the, so suppose if 30th is day of surgery, so on 25th we will stop warfarin, and instead of warfarin what we will do, we will start low molecular weight heparin. Clear? So heparin will be continued then. So this is how. Yes, Kakul, very good. Human papilloma virus for the previous question, and in this question stop warfarin, and this is around how many days? 4 to 5 days before surgery, okay, and then you can replace it with low molecular weight heparin. Then a patient of schizophrenia is on long term treatment with some drug. Now he is developing involuntary abnormal movements. What drug he is taking? So here the patient is a known case of schizophrenia, right? He is taking some drug. Now what has happened? involuntary abnormal movements. Now, what is this? Obviously, in schizophrenia is psychosis. So, what treatment the patient is taking? Antipsychotic. Okay, that's very clear. So, he is taking antipsychotic. Now, what has happened? As he is taking the drug for a long period of time, he is developing involuntary abnormal movements, and this is actually known as extrapyramidal effects or reaction. So, extrapyramidal effect. So, this has come now, right. So, these are extrapyramidal, especially you can say tardive dyskinesia. So, this is extrapyramidal side effect which has come now, and this is especially seen after typical antipsychotics like haloperidol, and therefore, we prefer giving atypical antipsychotics like olanzapine. Okay. So, this is the summary of this particular question. So, this is extrapyramidal side effect, and the patient is taking typical antipsychotics, especially haloperidol. Okay. So, this is enough for this session, and I have tried to include all the questions from derma, anesthesia, radio, psychiatry and ortho, and I am very sure you must have enjoyed the session. Thanks for joining me at this moment of time. We will meet again. See you. Goodbye. Take care.